Good afternoon, everyone, and thank you so much for joining our webinar today with the National Conference of State Legislators titled Long-Term Services and Supports and COVID-19, Ensuring Access to Services. My name is Samantha Scotti, and I'm a Senior Policy Specialist with the NCSL Health Program, and I will be your moderator for today. So before I introduce our speakers, I did want to go over a couple of quick housekeeping items. Today's webinar is a platform for information exchange. So we invite you to engage in the audience chat box by either entering your questions or answering questions here. The chat box, we want you to build some comfortability with using the chat box. So we do invite you now to enter your name and the state from which you're joining us in the audience chat now. We will also be holding a formal Q&A with the presenters after their presentations today. I also want to briefly mention the resources tab. So above the presentations, you'll see a tab titled Resources. Here you can find a PDF version of the slides from today, as well as a handful of session resources related to this topic. Another tab next to this is labeled Speakers. Here you can find the bios for all of our speakers joining us today. The webinar platform we use is optimized using Google Chrome. Other web browsers do work, but we recommend if you're experiencing any technical difficulties to log off and log back on using Google Chrome. If you still have technical difficulties, you can email registration@ncsl.org and we will have a staff member ready to help you. Today's webinar is being recorded and will be available on NCSL's website in approximately 1 week. And I also want to thank the Health Resources and Services Administration for their support of today's webinar. So now that our housekeeping is out of the way, to the point of you all joining us. So the COVID-19 pandemic is a global crisis that may have greater implications for individuals using long-term services and supports, as these populations are particularly susceptible to severe illness or death caused by the coronavirus. Now, to level set here, when I say long-term services and supports, I'm referring to a range of health-related and social services aimed to assist individuals with functional limitations because of impaired mobility, impaired cognitive function, chronic disease, or other complex medical conditions. And these services can be delivered in a variety of settings, including an individual's home, community, or institution like a nursing home or assisted living facility. So today's webinar will highlight a range of policy options for legislators aimed to ensure safe and secure delivery of these services. So a little bit about today's program. We have the privilege of being joined by a handful of national experts. First, we will hear about state strategies to leverage federal and state authorities to ensure access to long-term services and supports from Stephanie Anthony and Alexandra Gould from Mnet Health. After their presentation, we'll hear about strategies to support the direct care workforce from Kelsey Ruan with the National Governors Association. And finally, we'll hear from my colleague, Kelly Hughes with NCSL, highlighting some different pieces of legislation that NCSL has been tracking related to this topic. So with that, again, I thank you all for joining us, and I turn it over to our colleagues from Mnet.
Okay. Hi, everybody. Good afternoon. And I'd like to start by thanking NCSL for including Mnet in this important session on ensuring access to long-term services and supports during the COVID-19 pandemic. For those of you who don't know us, Mnet Health is an integrated legal and consulting firm that works with private and public sector healthcare clients, including many states across the country. COVID-19 has had such a devastating impact on populations who use long-term services and supports. As Sam said, these are folks who, because of their age or chronic conditions or disabilities or the settings in which they live, really have been particularly hard hit by the COVID-19 pandemic. We are, we're so grateful to the SCAN Foundation for supporting some of Mnet's work in this area, including a new LTSS state resource guide that describes how states have responded and continue to respond to the COVID-19 pandemic to ensure access to services for these individuals. And we're going to share some of our key findings from this work today. So for the next 20 minutes or so, Alex and I are going to describe the impacts that COVID-19 has had on the LTSS system. We're going to highlight innovative ways states are using federal emergency flexibilities and funding to quickly respond to the pandemic and remove barriers and access to care. And then we're going to highlight some lessons learned during the pandemic and ideas for strengthening the system going forward. So we actually first published the LTSS State Resource Guide back in June of 2020 when we were just 4 months into the pandemic. A lot has happened since then. It was actually our highest viewed thought piece last year, which really indicates how important this issue is to people across the board. Nearly a year later, just a few weeks ago in February, we released an updated guide with continued support from the SCAN Foundation, in which we were able to significantly update and enhance the resource guide with new information, new types of regulatory flexibilities, and new state examples, which Alex is going to get into in more detail. The resource guide is linked here. It's probably also in your resources tab. But this guide was informed by a review of states' approved emergency regulatory flexibilities, states' use of federal emergency funding, such as CARES Act and FEMA funding to support the LTSS system, state administrative actions, and then we also did targeted interviews with states to better understand how these changes were being implemented on the ground and really having an impact on the lives of consumers, their families, and their caregivers. In a subsequent slide, Alex is going to describe the different vehicles and authorities that states use to obtain these regulatory flexibilities. So the impact of COVID-19 on LTSS. As you now have all seen, COVID-19 really has had a devastating impact on the LTSS system, and particularly on residents of nursing homes. Nursing home residents were particularly vulnerable, and still are particularly vulnerable to contracting and experiencing severe complications of COVID-19 because of who they are. They're typically frail elders or people with chronic conditions, many with cognitive impairments and other behavioral health conditions, and because of where and how they live in congregate care settings with shared bedrooms, shared bathrooms, communal dining, with little ability to practice social distancing. As of February 25th, nursing home residents represent 5% of COVID-19 cases and over a third of COVID-19 deaths. And I would just note that that is higher in some states. Some states are up to about 65% of their deaths for nursing home residents, but they represent only 1% of the population. So as you can see, this is a population who's been disproportionately and significantly impacted by the pandemic. The takeaway on the slide is really in the blue header that COVID-19 didn't create a lot of the problems we've seen over the past year in nursing homes. It exacerbated long-standing underlying systemic issues affecting nursing home care and really the broader long-term services and support system. First, due to existing staffing shortages, old and outdated physical plants, and ongoing struggles with infection control, most nursing homes were unprepared for the threat of a widespread infectious disease pandemic. Second, and this is actually from my perspective one of the biggest systemic challenges, long-term care facilities and the long-term care system more broadly, generally not sufficiently integrated into the larger healthcare system in terms of clinical care coordination, communications, health information exchange. And this really had a huge impact on the early prioritization of personal protective equipment, the PPE like masks and gowns, in terms of testing, in terms of state technical support, where they were really focused on hospitals and protecting hospital surge capacity and not as focused on nursing homes. This did change over time as the challenges that nursing homes were facing became clearer. Third, state regulatory and oversight agencies, which are really critical to helping ensure resident health and safety, had to stall most types of surveys and inspections for safety reasons at the outset of the pandemic. But even prior to COVID, really have been chronically under-resourced and are really guided by federal and state survey and inspection requirements that focus more on finding and penalizing violations rather than identifying systemic issues and improving quality of care. And finally, the long-term care system is highly fragmented, meaning it has lots of different types of sizes and types of providers, many of which are not typically equipped with the technology or processes that were needed during the pandemic to quickly collect and report data that, to help support a wide-scale state public health emergency response. COVID-19 also exposed long-standing racial and ethnic health disparities in the long-term services and support system, both for care recipients as well as for long-term services and supports direct care workers, such as home health aides, personal care attendants, and certified nursing assistants or aides. And as the last bullet indicates, recent studies found that nursing home quality is measured by the CMS or Medicare star ratings was really not the major contributor to outbreaks, and most nursing facilities across the country were impacted by outbreaks. The most common contributor to outbreaks in nursing facilities was actually the spread of COVID in the surrounding community, where we know that communities of color were hardest hit by the pandemic. Direct care workers, which we're going to talk a little bit about more later, particularly in nursing facilities, are disproportionately women of color. And due to the low wages in this workforce and other workforce challenges, often work multiple jobs across multiple different types of healthcare settings, and were unknowingly contributing to outbreaks in facilities. With respect to nursing facility residents themselves, studies have showed that nursing facilities with a disproportionate number of racial and ethnic minority residents had significantly higher COVID cases and deaths than other nursing homes. So really exposed health inequities that we've seen across the healthcare system. While the media focused mainly on the impact of COVID in nursing facilities, the 10 million people of all ages who use long-term services and supports in their homes and communities have also been significantly and adversely impacted by the pandemic. This was primarily because of disruptions in access to care and services due to COVID impacting them or their families or their caregivers. For caregivers, this was due to disruptions in care was due to stay-at-home orders, lacking access to childcare, a school shut down, having inadequate access to PPE, or having to isolate because they became sick and were exposed to COVID. Similarly, care recipients, they were also initially shut in their homes, so couldn't have people come into the home or go out to receive care. There was fear of exposure, there was actual exposure in quarantines, or their community-based providers, such as a PACE center or adult day healthcare center, had to shut down. So really, big access problems, particularly at the outset of the pandemic. Despite these challenges, COVID-19 really did reinforce and actually increase people's desire to receive care at home. And a major focus of future system reform should be focused on expanding access to care delivery and staffing models that support people to receive services safely in their homes and their communities. So I'm going to turn it over to Alex now, who's going to talk about what states have done to address many of these challenges that I just identified during the pandemic, and also hint at what is needed to strengthen the system overall. Thank you.
Thank you so much, Stephanie. So I'm going to provide a couple of overall observations about what states are doing and provide some examples. But states have been doing a lot. So I would encourage folks to take a look at the resource guide that Stephanie mentioned. There is a link on slide 5. It should be in the resources tab. There's a great deal more detail about what states have been doing in that resource guide, more so than we could ever hope to cover in this format. So these are the flexibilities, the federal and state authorities that are available to implement the types of flexibilities that we're going to be talking about. States had a number of authorities, both federal and state, and for the federal authorities, CMS did provide tools like application templates or technical assistance to states, which made it easier for them to take advantage of these flexibilities, which was particularly useful to states that perhaps had less experience responding to disasters. When we were doing the state outreach that Stephanie talked about, we heard from states like Florida and North Carolina who have experience with the hurricane season and stuff like that, that they were able to get their emergency flexibilities online much quicker than some other states. So 1915C Appendix K authorities, these are the primary vehicles that states use for LTSS flexibilities. They apply to both 1915C waivers, but also 1115 waivers. On the 1115 waiver, but it's for HCBS that would states you authorized under an 1115, but those services could also have been authorized under a 1915C waiver. And all states, including the District of Columbia, have at least one approved Appendix K. 1135s, those are used to target a wide range of Medicaid, CHIP, and Medicare requirements, and CMS issued a lot of these in blanket waivers. So the state-specific 1135 waivers that targeted LTSS were pretty limited, but a lot of the blanket waivers did impact LTS recipients and providers. Disaster spas are also used for a wide variety of Medicaid flexibilities, including an eligibility and enrollment criteria. But disaster spas in terms of LTSS can only be used to target LTSS that are authorized under a SPA. And then 1115 disaster waivers were really used in much more limited capacity. There's only about 10 states that have used them, and most of them since the summer. Most 1115 disaster waivers were used for HCBS type flexibilities that are available under Appendix K, but were currently being provided to individuals who receiving LTSS under a SPA authority. In terms of expiration dates, in late last year, CMS recognized that, excuse me one second. CMS recognized that the public health emergency was probably going to last through 2021. And so they extended a lot of the expiration timelines. Appendix K, though they each had their own, excuse me one second. Though Appendix Ks each had their own end date, CMS has allowed for states to submit extensions that, excuse me, that, sorry, Stephanie, can you jump in, please? Thank you, I appreciate that.
Yep, no problem. Okay. Okay, so I think the point of the end of this slide that Alex was going to mention was that the public health emergency is now going through 2021, and states are still really in the midst of this. I think when we first started doing this work, we were really going to start focusing on, okay, they're going to start thinking through how to wrap these up, how to unwind these, how to, you know, what's next, what lessons learned did they have, and what in terms of making some reforms permanent. And because the public health emergency has really been extended through 2021, states are still in the process of really not implementing, but monitoring monitoring the activities and how they're impacting consumers. And they're still really in making sure that, you know, folks can access care. Let me go here. So, you know, I think looking across everything, we looked across volumes of regulatory flexibilities that states have put into place over the past year. And, you know, from, you know, June of last year to February, it was just exponential, the number of states that submitted these applications for these different regulatory flexibilities, as well as the different types of regulatory flexibilities. So when we looked across the regulatory flexibilities that states have deployed, and then also talked to the states I mentioned earlier, we really wanted to get an on-the-ground impact of, you know, which ones have made the most impact. And the four that really did rise to the top across the board were about maximizing remote service delivery. And again, this is the use of, you know, I don't like to use the word telehealth, but I think it's a very common word to folks, but using, you know, expanding the use of telehealth and expanding the use of remote service delivery to ensure access to care. Even if you couldn't physically see a person in person, there were things that you could do safely through remote service delivery. Expanding and stabilizing the provider workforce. This is something Kelsey's going to talk about in more detail, but this was probably one of the biggest ones that states focused on. And, you know, again, I was mentioning earlier how, you know, either adult day health centers shut down or people couldn't get out of their house. So there was a lot of activity around thinking about ways to expand and stabilize expand the workforce to ensure that people could receive services. And sometimes this meant expanding access to paid family caregiving. So family caregivers who were in the house already could continue to provide services that an external person couldn't do by coming into the house. And it also was about making sure that there was enhanced pay and rates in place to support, to support the work here. Maintaining continuity of care and this is really about taking a lot of care management activities, whether it was assessments or care planning or reassessments of need, and kind of easing some of the requirements around there to ensure there was just seamless care and not breaks in care while you waited for someone to be able to come in and do a needs assessment, really continuing care there. And then finally, extending home care to new populations. There was a lot of thinking around getting access to services earlier to people, as well as getting new types of services to people. So there was a lot of thinking around expanding home care. Okay.
And Stephanie, I can come back. Sorry, that's
Go ahead.
one of the joys of our current situation. Thank you so much, Stephanie. So diving a little closer into maximizing remote service delivery, this was really the primary focus for good reason as well. And it was both about moving services to the remote format, but also supplementing in-person services with remote formats. So states did things like authorizing remote delivery of LTS benefits that previously could only be delivered in person. They also changed limitations on available LTSS via remote service delivery. That included things like raising the maximum number of remote visits that a person could receive within a week, or even lifting those limits altogether. They also authorized assessments and care planning to be done remotely, and we'll come back to that a little bit when we talk about continuity of care in a couple of slides. And they also added assistive technologies. California's example on this slide is a really good demonstration of that. And when it comes to assistive technologies, another thing that states were really mindful of was addressing the digital divide, which is something that we hear a lot about. But the digital divide in LTSS, it certainly is an issue related to race and geography, but it's also related to basically skills and abilities. So LTSS populations were often seniors or people with certain disabilities or cognitive issues that may make using remote technologies difficult. So that was something that states tried to really address. The other unique piece about LTSS is that not all of it can be delivered remotely. Things like assisting someone with bathing or getting dressed obviously can't be done remotely. In those situations, states really looked to the emergency authorities to think about different ways to provide those in-person supports. So that would include things like providing what states call the doorstep wellness checks, showing up on someone's doorstep just to see how they're doing, providing a Thanksgiving meal, leaving it on the doorstep. It's also things like expanding self-direction opportunities, so that an individual can hire someone who's already in their house to provide services. And then it's also thinking about different ways to provide services. So we heard from states who move their adult day services into a beneficiary's home or into an outdoor setting. This next slide really just kind of highlights the issue around the digital divide for certain types of populations, and particularly older adults. You can see in this slide, it's probably a little bit hard to read, that between March and April, in the first month of the shutdown and the stay-at-home orders, the number of Medicare fee-for-service weekly telehealth users went from basically 0 to 1.7 million. So a really significant increase. But it's likely that number would have been even higher if not for some of the limitations that are faced by the 65 and over population. Research has found that more than a third of adults over age 65 face challenges in terms of engaging with remote care. Stephanie mentioned this earlier, the workforce around LTSS prior to the pandemic was already under a great deal of pressure. There are issues in terms of high caseloads, high turnover. It's a very difficult, sometimes dangerous job, and the pay is often quite low, and that all basically resulted in a workforce shortage that was exacerbated by the pandemic. So in order to respond to that and make sure that some of the most vulnerable populations in these states were able to access LTSS, states expanded opportunities for self-direction, so individuals could hire their own providers. They allow family members and other close relations, so neighbors, family, friends, to be reimbursed for providing personal care services. They allowed different types of providers, including case management entities, to provide direct care services. They often allow providers who were licensed in other states to come into facilities and provide services. We saw that a lot in nursing homes early in the pandemic. And also, they modified what type of providers could provide certain services. So I think if you see the Missouri example below, they allowed graduate nursing students who had not yet been licensed to provide private duty nursing. And the examples below on this slide, they were pretty common across all states, but I think they're good representative examples. Next bucket is around maintaining continuity of care. And as I said before, there is some overlap with this category and the remote delivery of service category, mostly because states use remote technologies to conduct assessments so folks could stay safe in their homes and limit their exposure. The Rhode Island example on the slide is a good example of that. But we also saw states modifying their required timelines for assessments and reassessments and for care planning. Hawaii here is a good example of that as well. So there were different ways that states made sure that their beneficiaries did not lose care. And North Carolina also was a good example of states modifying their verification requirements by accepting self-attestation for certain eligibility pieces. And lastly, we know that many states were working on rebalancing their LTSS programs towards home and community-based settings prior to the pandemic. And like with telehealth, we saw the pandemic accelerate that shift. But unlike telehealth, what remains to be seen is if that shift is going to be permanent. I think we know that states are going to really try to embed the new telehealth flexibilities on a more permanent basis. We're not sure what that looks like yet on the home care front. We know now that there are significant issues in congregate care settings. Stephanie had some really powerful details and statistics around their nursing home setting. And that has been well documented over the past year. And we know that states are making efforts to address those deficiencies. But the issues in congregate care settings are longstanding. They're going to require long-term and well-resourced strategies to address it. So we're hoping that the states will take the examples they have seen in their emergency flexibilities, which I will address in a second, and really use that to convey them into long-term system reform. So in terms of the emergency authorities, states prioritize folks who had COVID-19 or were quarantined to get them into waiver services. The Indiana example here is one demonstration of that. They also allow delivery of home and community-based services in alternative settings that normally wouldn't be considered a home or community-based service, a home or community-based setting, such as an adult day setting. They also changed their eligibility criteria so that more folks could get access to home and community-based services, added new types of services to waivers. Iowa is an example of that. And they also modified the approval and pre-authorization requirements, again, just to maximize the amount of folks who are able to access these services outside of congregate care settings. And just to come back to nursing homes 1 second, because we really want to highlight some key strategies that states use to respond to the crisis. once what was happening in the nursing homes became clear, we saw states really leveraging the authorities they had on their own. There was not necessarily a need for a federal authority in these cases, and also leveraging emergency funding, both state and federal funding, to respond. Michigan is a great example of that. They recognized the need for cohorting and established regional hubs for folks who had COVID-19 to make sure that they weren't had people in nursing homes who were in individual rooms that both had COVID-19 or didn't. And Maryland had a really interesting approach that I think became more common as the crisis progressed, where they set up some strike teams using the National Guard to send them into nursing homes to help with testing, to help with clinical interventions, to assess sites, to help with supplies. And I think we're now seeing a little bit of this applied to the vaccine rollout approach, since we know that the nursing homes were so disproportionately impacted, and we're seeing a lot of really good impact in terms of vaccine rollout. So in terms of emergency funding, there were really a couple of sources that states use. Of course, there was the CARES Act, Coronavirus Relief Funds, FEMA. A lot of states were able to leverage general state funds. And states were also able to increase revenue through Medicaid because they had increased rates. So the federal matching funds coming in was a way to increase some revenue flow. And they really directed that money towards all the activity that we've discussed so far. A very common thing we saw was an increase in retainer payments and hazard pay to address the workforce shortages that we talked about. Obviously, with new services being authorized, there's going to be new needs for reimbursement, so it was used in that way. The funding for deployment teams, that's the strike teams that we talked about. There was also about $5 billion earmarked for nursing funds that came directly from the federal government to nursing homes that states did not have involvement in, though we did hear that some states were providing technical assistance to their nursing homes to help access those funds. So next steps, we do know that states post-pandemic planning has to consider some near-term issues, but we are seeing states trying to take the lessons learned from COVID and all the changes they've implemented through these flexibilities and use them to advance broader system reform. We do think that that's going to require assessing what the LTSS system looked like prior to the pandemic, and also assessing the impact of these temporary emergency flexibilities on those systems, and then putting together a real formal and clear and long-term roadmap. A flag that we want to make sure we get out there is that it is likely that the public health emergency is going to last for the end of 2021. But in December, CMS did put out some guidance on what states should be thinking about and considering as they look ahead towards the unwinding of the PHE, and that is addressed here. So I am pretty sure that we are going to save questions for later, but I defer to Sam on whether or not we should proceed.
Thank you so much, Stephanie and Alex. As she said, we're going to hold our questions to the end, but I do want to remind attendees that they can enter their question at any time into the chat box. And with that, I'm going to turn it over to Kelsey Ruan with the National Governors Association.
All right. Well, thank you so much. And thank you to NCSL for having me today. My name is Kelsey Ruan, and I am a health policy analyst with the NGA Center for Best Practices. And today I will be talking about our latest publication on the direct care workforce and introduce some of our future work on longer term retention and sector recruitment strategies. Before going into more detail, I want to just briefly give some background on the National Governors Association. The National Governors Association serves our nation's 55 governors and consists of two main sides. We have the Office of Government Relations, which is our lobbying arm, and then the Center for Best Practices, which is our research arm, and kind of operates as a hybrid between a think tank and a consultancy. So before we dive in, when I talk about the direct care workforce, I'm primarily talking about workers such as certified nurse aides, home health aides, personal care attendants, and similar workers who are working entry-level jobs in the healthcare sector and employed largely by long-term care settings, providing services in the home and providing services and settings for individuals with disabilities. As our presenters from Mnet mentioned, and as many of us on the call know, before COVID-19, states and employers already faced tremendous challenges with recruiting and retaining direct care workers. The public health emergency definitely exacerbated many of the existing issues, such as low wages, lack of clinical opportunities, and really the emotional and physical demands of the work. In fact, a lot of employers before COVID-19 found themselves competing with jobs in the restaurant or the service industry because the pay was really roughly the same. And a lot of those other jobs require less training and are less emotionally demanding. Additionally, COVID-19 made it really difficult to have in-person testing and in-person training due to fear of infection and largely due to the social distancing policies and temporary shutdowns. With all of that said, this is a really interesting and unique time to be focused on the direct care workforce because it's really putting a spotlight on the demand for the job, and it's providing an opportunity to recruit people who are interested in the field, particularly with, as I mentioned, those service and those restaurant jobs where there was some temporarily reduced demand for those. So it provided opportunity for people newly looking for work or previously interested to participate in some expedited trainings. So due to these federal and state flexibilities that I'll get into in a moment that allowed expedited training and certification, there's kind of an influx of individuals who have some experience, some training, and could potentially be retained in the sector if they choose to keep practicing and if states provide a pathway for them. There you go. So that brings us to our new brief on emergency action taken during the pandemic to expedite certification and training for some direct care workers. In this brief, we cover the short-term federal and state flexibilities to scale up the direct care workforce and some state strategies that have been taken to strengthen the health workforce pipeline even after these waivers are lifted. So for context, the Federal Centers for Medicaid and Medicare Services waived requirements that nurse aides have to receive training and certification before working in a nursing facility for longer than 4 months. This action allowed states to offer significantly expedited training courses and get people into the workforce almost immediately. To help states with this effort, the American Healthcare Association developed an 8-hour online training, which helps prepare individuals to work as a temporary nurse aide or a TNA during the public health emergency. In total, about 25 states actually use this option to either fully or partially help people get all of the training that they need to operate as a full-time temporary nurse aide. For states who allowed it to partially complete the credentials, they may have added their own requirements on top of it, but still use the training to help get people into these settings as quickly as possible. So as I said before, these are people who are practicing, who have some training and could potentially be on a path to continue working in this sector, either in direct care or move up and work in healthcare services after the pandemic is over. So what states are grappling now is how much training is appropriate for this population, and what is the balance between helping give credit for the hours and the training that they received and worked during the pandemic, but also ensuring that the training that they received is sufficient. While these federal flexibilities were really helpful in expediting the process of recruiting and training workers, there are questions of, there's not going to be an 8-hour training after the pandemic is lifted. So what is the appropriate amount of training, and how can we help keep these people in the workforce, in the field? There are states who have already taken action to help keep these people in the sector. And depending on how a state wants to go about this and the authorities that they have, some states have used executive action and other states have passed legislation. The paper that we have includes examples from Pennsylvania, Indiana, and Wisconsin. And some of the actions that they chose were passing legislation allowing full certification for people who practiced let's say, for example, up to 80 hours during the pandemic, those people could take the exams required by the state, and then they can practice. Other states, again, partially allowed up to a certain amount of clinical hours to go towards the full certification. And once the person completes the additional testing and clinical hours, they can be certified as well. The idea is that people who practice don't have to repeat all of the didactic and all of the clinical training. In addition, there was some action taken for states for fully certified nurse aides, such as lowering the amount of training for full certification to the federal minimum, which is 75 hours. So states who previously had more stringent clinical requirements decided to just let them do the federal minimum so they could get trained and certified faster. So that brings us to our future work. Since finishing our publication, we've actually developed a longer-term project aimed at identifying best and promising practices for recruitment and retention of the direct care workforce. As I mentioned before, we have a really unique opportunity to work on the direct care workforce specifically, and we're in the research phase of identifying how states are approaching this issue. So for the first one, cross-sector collaboration is crucial because this is clearly a very multifaceted issue. And partnerships between agencies that have authority over health, licensing, higher education, and workforce are crucial because all of those issues really come together when trying to implement innovative programs in this area. Additionally, community colleges, universities, employers, and professional associations have been really key partners in states looking to implement these innovative policies. States have also used partnerships and cross-sector work groups to conduct research into their state specifically, and what would be the best practices for them and their situation and their authority. So that's also something to consider if there are subcommittees or work groups that could be convened. That's a good segue into the next one, which we've looked at a lot, which is career pathways. At NGA, we're very excited to also be partnering with our post-secondary education and workforce team. And we're trying to look at how healthcare sectors can facilitate things such as apprenticeships, earn and learn programs that allow people to move up in the health sector ladder. A very common pathway could be certified nurse aide to licensed practical nurse to registered nurse, which allows people to grow into higher paying careers and ultimately be retained in the sector while being able to make more money and do higher skilled labor. States have a really significant role in establishing these earn and learn or apprenticeship programs for opportunities who are, or for people who are looking to remain in the healthcare sector. Also, there are opportunities within careers, such as upskilling. So if someone wants to remain as a CNA or a home health aide for a little bit longer, there could be opportunities to give them more training or more certification, which allows them to stay in direct care if that's what they choose, but still ultimately have the opportunity to learn more, which could lead to higher wages. This is one of these areas that really, really highlights the importance of cross-sector collaborations, since these programs tend to be partnerships between multiple state agencies, employers, and academic institutions. So these second two, fee structure and wages and standardized roles, are ones that we're still looking into and very much in the early phase of researching. As I mentioned before, for fee structure and wages, these jobs are very difficult to recruit for and retain people in because they don't pay a wage that a lot of people can live on or that you can sustain a family on. We know that at least a few states took action to increase wages during the pandemic through things like Medicaid pass-throughs or a waiver to temporary increase reimbursement rates. And this is something that we're looking at to see if it could be a more longer-term strategy to really raise the pay of people who do this work. We're also looking into ways that the state can standardize roles. The regulation and oversight of these professions varies significantly, especially since many of these professions are certified instead of licensed. The certification process might be managed by a professional association, while the training and the certification might be managed by the state. So it's not always immediately clear to people what the process is and where they should go in order to receive training, in order to receive certification. Streamlining those requirements can really go a long way in setting clear pathways from one position to another. And we're very interested in state initiatives to kind of smooth over the process of recruiting and retraining and training for these issues. And additionally, standardizing the roles might help states really identify clear pathways from one role to the next. So these all kind of fit together. With that, that's just a little bit about our project that we're very excited about. And I will go ahead and turn it back to NCSL.
Thanks so much, Kelsey, for those remarks. And I do see some questions coming in the chat box here. So thank you so much for those. We will get to those at the end of the presentation. And with that, I will turn it over to my colleague with NCSL, Kelly Hughes.
Great. Thank you, Sam. And hello, everyone. My name is Kelly Hughes, and I direct our health access, cost, and coverage work here at NCSL. And I have the honor of rounding out this webinar on a Friday afternoon. And I'm going to just touch on, Alexandra and Kelsey and Stephanie all kind of touched on some of the topics that I'll be covering, but I'm really going to focus on state legislative trends and examples that we've been seeing here at we've been tracking here at NCSL. So let's get in. Okay. So as you know, there are many stakeholders involved in the oversight, regulation, and funding of long-term care facilities. And these stakeholders, including state legislatures, have pursued a number of strategies to prevent the spread of COVID within facilities, protect vulnerable residents, and also bolster the direct care workforce, or staff that work within these facilities, as you heard from Kelsey recently. So zooming in on state legislatures, since the beginning of the pandemic, our team has tracked over 76 enacted bills across 23 states relating to long-term care and COVID. But to do what exactly? So the legislation varies, of course, but most of the bills fall under three main buckets. The first one is public health protocols and state oversight. The second one is Medicaid provider rate increases and other appropriations and funding sources, as you've heard throughout this webinar. And then the third is visitation requirements. And this is one that we're really seeing trending in the media and also in research requests from legislators and legislative staff. So we'll take a few minutes to kind of unpack each of these topics and then provide some state examples for each of them. So the first bucket includes public health protocols and state oversight, but what exactly do we mean by that? So this relates to bolstering public health and infection control protocols. So both providing adequate PPE or personal protective equipment and prioritizing COVID testing in nursing home residents and the staff. So for instance, California enacted a bill establishing a statewide PPE stockpile for healthcare workers. And the bill also requires certain health facilities, including skilled nursing facilities and home health agencies, to maintain a supply of PPE for future public health emergencies. Additionally, some lawmakers have enacted legislation to enhance state oversight for long-term care facilities. So for example, Georgia established COVID-specific reporting requirements for assisted living communities, nursing homes, and personal care homes. And one of the requirements is that the facilities must notify residents and guardians of new positive COVID cases. The legislation also permanently establishes additional staffing requirements, increases fines for safety and quality violations, and requires facilities to develop pandemic plans for future outbreaks. So let's talk a little bit about funding and appropriations. So one, including increased reimbursement for providers. So we know that many long-term care facilities are underfunded and that low wages for their workforce may contribute to the high staff turnover that you've heard about. So in response, several states have increased Medicaid payment rates, which you've heard about during this webinar, to long-term care providers and facilities during the pandemic. So one example is Washington. Washington authorized the Department of Social and Health Services to increase Medicaid payment rates to skilled nursing facilities to support the COVID response. And then another example is Minnesota. They established an 8.4% rate increase for certain services provided by direct care workers, such as personal care attendants. And then also states are providing additional funding to facilities and the workforce. And a lot of states are using federal relief funding to do that. So Michigan, which we've mentioned earlier, Michigan used $1.4 million in federal CARES funding to conduct infection control surveys and provide trainings to staff on COVID mitigation strategies. And the bill also implemented a temporary $2 per hour wage increase for certain direct care workers at nursing facilities. And these include RNs, nursing assistants, and respiratory therapists. So that third bucket is our visitation requirements. And so this really gets at meeting the social and mental health needs of residents. It's an area where we've seen a lot of activity recently. And currently, legislators in at least 27 states have enacted or are considering legislation relating to long-term care facility visitation. So for example, Virginia enacted legislation requiring nursing homes and hospice facilities to establish protocols on when and how in-person visits can occur, and then also how the facility will provide for virtual visits. And many states, including Kentucky, are considering or have enacted legislation around establishing essential caregiver designations and defining compassionate care visits. So essential caregiver designations allow family members or friends to assist with daily activities and provide companionship to residents, whereas compassionate care visits allow family members and friends to visit loved ones under certain urgent circumstances that may be end of life situations, or if a resident's really struggling, acclimating and being recently admitted to a nursing facility. So again, I've mentioned this, but we anticipate that this is an area where we'll see more activity. It'll continue to surface and evolve as staff and residents and their family members get vaccinated. So that's a really quick overview of the many state actions we're tracking relating to long-term care. And I want to leave you with a few NCSL resources if you'd like to dig a little bit deeper. And with that, I'm going to turn it back to Sam so we can get to some of your questions.
Thanks so much, Kelly. And as she mentioned, we do track these pieces of legislation. So if you're interested in looking deeper at these bills, we can point you to that state actions on the coronavirus database that NCSL has on our website. So with that, we have some time for Q&A, audience Q&A here. The first question that we have here is around the impact of COVID-19 on long-term services and supports enrollment and that population specifically. So I will turn it over to direct this question to our colleagues from Mnet. Have you all been tracking how the pandemic has affected kind of the enrollment in this population?
Go ahead, Zach.
Oh no, Alex, go. You go.
I hope we're going to say the same thing. I don't think that at least I have seen any data specific to LTSS. We do know that waiver enrollment has increased because of the flexibilities we've talked about. Some states were able to prioritize enrollment into waivers. They were able to lift the cap on waiver enrollment. We do know that Medicaid enrollment has been impacted by the pandemic. So I think we can say that there's certainly some LTSS recipients in there as well. But I think it's an interesting question. It may take some time for the data to kind of work itself out. But that's Stephanie, anything to add to that?
No, that was exactly what nope, same answer.
Great, thank you for that. Our next question is around LTSS, the direct care workforce, and vaccinations. So I will direct this to Kelsey. Are you seeing any states prioritizing distributing vaccines to this workforce?
That's a great question. I actually am not the person at NGA who is tracking that, but let me go ahead. If you can give me 1 second, I will find our vaccination resources from our team members who do a wonderful job tracking that and put them in there. I don't want to make any guesses.
I think we can add, I have been, just because I'm obsessed with looking at the phases and who's in the eligibility groups across the country. So I do know some states are prioritizing nursing facilities, residents and staff were prioritized like in the first bucket, I think. And then home-based LTSS workers are in the second phase right now, at least I'm in Massachusetts, but they are, and I do think they split it between, nursing facility residents and staff, and then home-based LTSS workers in a separate category. But both, I think, are eligible and well underway getting vaccinated in many states, at least.
Can I add one piece to that? I think one LTS piece of the workforce that is being overlooked that states should consider are the self-directed workforce. So family members who provide personal care services to people in their homes or people in their families. When we have seen states, I think New Jersey, where I am, actually has extended eligibility for vaccine to what they call essential caregivers, which does capture the LTSS workers who are not agency or formal workforce. So I would say the informal LTS workforce is at real risk of being overlooked in terms of vaccine eligibility.
Good point.
And I'll just draw attention to what I just posted in the chat, which is our 50-state table of state approaches to allocating the vaccine. So that might be helpful.
Great.
Thank you for sharing those resources. And I do want to next address this question around efforts to track liability protections for skilled nursing facilities. I think my colleague Kelly Hughes right now is sharing a resource in the chat that tracks 50 state action around this. But if any of the panelists have anything to add in on this, if any of your organizations are tracking this, have heard from states, I'll first direct that to Mnet.
Yeah, so I will say that I have tracked this as a specific question from specific states around what are my peer states doing around, or my geographic peer states doing, what, you know, so I have looked at it in pockets in targeted geographic areas. I have not tracked it nationally, although, you know, Mnet's, our legal colleagues may be tracking it more than Alex and I are on the consulting side, but I have looked at it in pockets.
Great, thank you for that. And it looks like we are just running up on time here. I do see another question in the chat, and we will definitely follow up with you after today's presentation. But I did want to take this opportunity to thank all of our presenters again for joining us and for taking the time, and thank you all for attending. My contact information is here on the screen, so I'm happy to answer some follow-up questions after today's event. And I do also want to again thank the Health Resources and Services Administration for their support of today's webinar. And with that, that concludes our event today.